it's Dr. Kathy Miller coming to you from the 2019 ASCO annual meeting. I'm joined today to talk about updates in breast cancer by Dr. Hal Burstein,
Hi, Kathy.
good friend and medical oncologist in the breast cancer program at Dana-Farber, and now a professor of medicine at the Harvard Medical School.
I want you to have some respect for me now.
I always have, Hal. Thank you so much for coming in.
Well, as always, there's a lot of stuff going on in breast cancer here, and I think there's several important stories that people need to know about as we move forward into several new eras of treatment. So let's start with immunotherapy, because everybody's doing immunotherapy these days. So we got to talk about immunotherapy. And at this meeting, in contrast to last year, we have a couple of negative reports, which I think show some of the challenges of moving forward with immunotherapy in breast cancer. So there's a randomized study looking at chemotherapy with eribulin given with or without pembrolizumab in women who have hormone receptor positive breast cancer. And that study really showed no signal of activity for the pembrolizumab in that experience. And then a press release that came out about a week ago, but people are talking about here, was a study that looked at single-agent pembrolizumab versus chemotherapy for women with triple-negative breast cancer, and again, no survival signal there for the immunotherapy approach. So what's interesting to me is to learn from the previous experience with the impassioned data, which looked at atezolizumab and a nab-paclitaxel in triple-negative disease, and try and understand how we can build on that. So in that study, they of course chose triple-negative breast cancer, and they seem to have a biomarker with the PD-L1 immune cell expression in the tumor. These latter two studies did not use that.
So I want to ask you about the biomarker.
Yep.
Progression-free survival in impassioned for the entire group was 2 months improvement with atezolizumab. And in the biomarker positive group, PD-L1 positive, it was 2.5 months, which does not sound like great selection.
It's not great, but if you look at the survival data, the benefits are more robust. And if you look at our friends in lung cancer and some of the other malignancies where they're using IO regularly, I think it's fair to say they're still teasing out where the biomarker threshold should be. So I would not maintain that the PD-L1 IC thing is the be-all and end-all. I think it's just where we start. And probably enriching patients who have some biomarker driven is going to be the way to go forward with the IO.
So we did have an update for the impassioned study here, looking at more overall survival data. The first report was very immature OS data. It's still immature OS data, but getting a bit more. Hazard ratios starting to go up a bit. Do we know when we might actually see final OS data?
It's an interesting question. I don't know the answer to that. We've been using this. I mean, I will confess that in our practice, we are using this. So I will tell you personally, as I test more patients, I don't see the 40% level of expression, or 40% of cases with the PD-L1 positivity. I don't know if you've been looking at that in your series.
We've only tested a few. The testing itself, it is just a complicated mess of chaos to me, because what antibody you use to test, what cells your pathologist looks for is different depending on what IO agent you're talking about and what tumor type you're talking about. So while they have 3 of those assays at IU, they don't have the one used in the atezolizumab trial. So we have to send our samples out. So we've only tested a handful. So I don't have a good sense yet if it looks like we're near 40% or above or below.
So I guess really where I was going with this is I think that what we have seen, we sort of put our foot in the water for the immuno-oncology piece in breast cancer, but we actually have to figure out a lot of stuff still until this becomes more widely used. So a second big story, I think, has been updates on the role of CDK4/6 inhibitors, and the data released today for the update on the MONALEESA-7 trial showed that what we already knew, which is there's an improvement in progression-free survival, but now actually a reasonably robust improvement in overall survival. And you, perhaps more than anyone in the breast oncology community, has wrestled with the question of PFS versus OS as endpoints, but I think it actually is very gratifying to see that there is a survival benefit for these drugs, and validates the approach that I know your center and ours have already taken, which is that these are very commonly used products in the management of ER-positive metastatic disease.
And that's starting to become a consistent message across a couple CDK inhibitor trials now, that with a longer follow-up, these are patients with ER-positive disease, so survival events, thankfully for our patients, are often years later.
Exactly
so it does require patience to get to to those results.
It does, and
but there's a consistent story building.
And
now.
there was a nice update of an old SWOG trial this past few months that was in the New England Journal of Medicine, where adding fulvestrant in first line to anastrozole actually improved survival. I think it's unclear how that relates to a more contemporary practice setting with the use of the CDK4/6 inhibitors. But again, it underscores the point that drugs that are going to be good are really going to have a long-term survival impact, and it's important to keep looking for that. So the other study I liked in the CDK4/6 space was an international study where they compared palbociclib with endocrine therapy versus capecitabine, the chemotherapy product, to see which approach would be better.
And that one I thought was really important.
Yes.
Because I think many people in the community, especially if you have somebody who's recurred with a shorter period of time on adjuvant hormone therapy, or if they happen to have some visceral disease, I think there is still many who are too quick to jump to chemo.
So as a sidebar, Hope Rugo and I updated the ASCO guideline on management of ER-positive metastatic disease, and when we pulled the data for that, in contemporary practice, something like 40 to 50% of patients still get chemotherapy as initial treatment. So in this study, which was really quite clever, I thought, actually the CDK4/6-based regimen with palbociclib outperformed capecitabine chemotherapy in first line. Again, progression-free survival estimates. But exactly to your point, underscores that endocrine therapy with targeted treatment should be the first approach for women with ER-positive metastatic disease in almost all situations. I'm sure you see, and we occasionally see the true visceral crisis, but those are rare.
They're particularly rare as an initial presentation of metastatic disease with ER-positive disease. Probably the times that I wouldn't use a CDK4/6 inhibitor are the other end of the spectrum.
Meaning?
The lady who's now 85, she had her first diagnosis of breast cancer at age 60. She's just now recurring and she's not symptomatic. I'm not sure I really need to jump to that as initial therapy for her.
That may be. They've looked, the FDA has looked, and what's interesting is that in terms of clinical benefit, age, all the biologic subsets, all the volume of disease measures, disease interval, none of those actually predict benefit or not from the CDK4/6. But of course, there are patients who just don't need it at the moment, and I think that's a good point that you make.
So I want to ask you about data that I don't think is updated at this meeting, but we have a recently approved targeted therapy in ER-positive metastatic disease.
Right.
Just recently
like 2
approved.
weeks ago.
But I'm interested in your experience with it, and I'm particularly interested in your thoughts about a quandary we're going to face now when somebody with a PIK3CA mutated ER-positive tumor pops up.
Yeah.
Is it a CDK4/6 inhibitor? Is it a PI3 kinase inhibitor?
Fair question. So,
what are they best served by getting?
20 years of research in PI3 kinase inhibitors, and the problems were probably drug targetability mostly because they were relatively dirty drugs. The alpelisib approval is for a relatively alpha-selective PI3 kinase inhibitor, but also with a better toxicity profile. Though the drug still has some side effects, and we can come back to that. So the SOLAR-1 data from Novartis showed that the drug improved progression-free survival in second-line management of ER-positive metastatic disease, FDA approval. An important thing about the FDA approval is they actually approved it based on a companion diagnostic, and even a cell-free companion diagnostic, which is, I think, exciting because it kind of opens the door for that.
Many of these patients will have bone-only disease where getting a biopsy is more challenging, tissue processing more difficult. So a liquid companion diagnostic makes this easier to employ.
Agreed. And the mavens tell me there apparently are 11 PI3 kinase mutations that might predict sensitivity to alpelisib. Fortunately, I think 80+% are from 1 or 2 mutations, and so you don't have to look that hard. You won't miss that many cases. But I think this is going to begin to open the door to cell-free or plasma DNA testing for wider use in breast cancer genomics, which we're catching up to our lung cancer friends again. So I personally think this is, at the moment, probably a second-line drug after the CDK4/6 inhibitors. And I say that because we now do have the survival benefit for the CDK4/6 inhibitors, and also because in subset analyses, they actually showed that this drug alpelisib still has robust activity in patients previously treated with the CDK4/6. So to my mind, that's an argument for treating those patients after the CDK4/6 inhibitor therapy. What's your practice approach going to be?
So like you, this is a new approval, so I haven't faced this situation yet, but we've certainly thought about it. And I think we also would tend to use a CDK4/6 inhibitor first followed by the PI3 kinase inhibitor, more swayed by the toxicity profile, honestly.
So that's an important thing because oncologists are going to have to deal with the toxicity profile, and about 60+% of patients are going to end up with hyperglycemia, and many of them will need to start a metformin type treatment. And inevitably, I'm sure that these will be laboratory results called in at 4 o'clock on a Friday afternoon. So we're going to have to brush up on how to effectively use these drugs to control the symptoms. It is expected that that goes away once the patient stops the alpelisib. So it's not like a lifelong commitment to this. I liken it to more of an anti-nausea treatment for chemotherapy. It's something you have to do to support people through the treatment.
But it's going to be challenging because we are going to have to brush up on management of hyperglycemia, management of diabetes. It also means we're going to have to remember that we put the patient on metformin when we stop their PI3 kinase inhibitor, so we don't end up having to brush up on management of hypoglycemia.
Good point. The other thing people often get with this is a rash, and it's not the typical EGFR inhibitor acneiform rash. It's more of an urticarial type rash, and I believe that the recommendation is for one of the over-the-counter antihistamines like Zyrtec or something. But things that are new to medical oncologists in the breast cancer space we'll have to work on and sort of figure out how to tweak a little bit.
Now, I think for the first time ever asking you about things you're excited about at the meeting, you did not mention HER2 a single time.
Right. So this is progress. We've got something else to occupy our thoughts. But there still, of course, are data for HER2 positive disease and two interesting studies that are neoadjuvant studies, which have looked at the use of TDM1 or adotrastuzumab emtansine, the antibody drug conjugate, as a neoadjuvant approach, comparing that against chemotherapy plus trastuzumab plus pertuzumab based approaches. One study, an update of the so-called Christine trial, which was a Genentech sponsored study, and the other, a presentation from Johannesburg and colleagues in Sweden. So the interesting thing here is that in some of the reports, actually, chemotherapy plus trastuzumab plus pertuzumab actually had a higher pathologic complete response than did the TDM1 based regimen. But what they showed in the long-term follow-up with Christine is that if you did achieve a pathologic complete response with either approach, your long-term results were the same. And so this fits with this theme in breast cancer of trying to get away from the chemotherapy. A lot of people are calling it de-escalation, but it's really adding different drugs, not really getting rid of drugs. But the emerging idea here is, well, let's use enough therapy that we give the patient a good chance to have a pathologic complete response. For those who do, they might be done with their treatment. And for those who don't, then we can add more sort of out back. And this is consistent with the message that emerged from the Catherine trial, where patients who had residual HER2 positive disease after trastuzumab-based chemotherapy benefited from the addition of TDM1 afterwards.
It is a great opportunity to think about what can we avoid doing in a toxicity way to our patients. And perhaps not everybody needs everything to get that good outcome.
And the numbers are pretty similar. So it's not like, 50% PCR with one approach and 10% with another. It's, in the Christine trial, it's like 55% versus 45. In the Johannesburg study, it was more like 45% for each group. So I think it's a very exciting approach. And what we still don't know, though, truly, is whether in the long term, there is some benefit for chemotherapy. That yet still to be proven.
So that's always going to be challenging because we give people neoadjuvant therapy for the same reason you give them adjuvant therapy. It's not really about the breast. The goal is preventing distant recurrence.
Yes.
Those neoadjuvant studies will continue to follow patients, but since their primary endpoint was what happened at surgery, they're always way too small to do anything but tease us.
And even in the Christine trial, the data they're talking about are 3-year follow-up, which, again, isn't huge. There was a related study that my colleague at Dana-Farber, Otto Metzger, ran, where they were specifically looking at outcomes in so-called heterogeneous HER2 positive cases. So, those cases where there's like a little bit of FISH amplification, but their tumors
the bane of the tumor board.
Exactly. And those cases, it's a mixed picture. And so a lot of the idea of the de-escalation really will hinge on the quality of the pathologic review, which is not a trivial thing to figure out.
Well, it's always a pleasure to talk to you, Hal. Thanks for coming in and updating us about this year's meeting.
Happy to be here. Enjoy the meeting.
And thanks to you, our listeners. This is Dr. Kathy Miller from ASCO 2019.